right, so our first topic today is, there we go. We're essentially going to talk about the cardiac muscle as a pump. You know, it is in fact a muscle that contracts. It gets smaller in multiple dimensions. And because of the valve system that's present, that turns the heart into a pump that only pumps blood forward, at least in the normal case. And we'll connect that to some of our action potential learning that we did last week. So there's your objectives. I'm not going to go through all of those. Okay, so the basics of the heart, you've all had cardiac anatomy at some point in your life. If you, at this point, are not 100% sure of blood flow through the heart, take some time tonight and go through that a bunch of times, okay? Because it is something I'm going to assume that you know. So as we see here, you know, our heart is essentially a four-chambered pump, two on the left and two on the right, that are fused together at the interventricular septum, which is this aspect right here, right down the middle. So we have a right atrium and a right ventricle, a left ventricle, and a left atrium. The right side of the heart receives blood from the body and pumps blood out to the lungs. The left side of the heart receives blood from the lungs and pumps blood out to the body. Now, typically speaking, when we look at cardiac diagrams or pictures, you'll see the blues and the reds, right? Blue is unoxygenated blood. In other words, blood that has lost its oxygen passing by cells, i.e. blood coming from the body. And the red blood is blood that has come from the lungs and is therefore chock full of oxygen and is ready to go out to the body to deliver that oxygen, okay? The valves that are present, we have four valves. We have a tricuspid valve, which sits between the right atrium and the right ventricle. We have the mitral valve, or bicuspid valve, that sits between the left atrium and the left ventricle. And then we have two sets of valves called the semilunar valves. That's the pulmonary valve and the aortic valve. And the anatomy of the heart makes it so the pulmonary and aortic valves practically sit one behind the other. Okay, so a lot of times when you see pictures, you're only going to see the pulmonic valve, but tucked in behind it is the aortic valve. Okay, so we have four valves, four chambers. Each of these valves performs the same function, which is to prevent blood from flowing backwards. Okay, that's essentially how these valves work, and we'll talk more about that function either later today or tomorrow. Okay. Now, the last property I want to remind you about is rhythmicity. The heart, all the cells of the heart have a tendency to contract in a pattern. They contract and relax, to such an extent that if you were to go in and carve out a little muscle cell from way in the corner of the heart, take care of it in a cellular broth or bath, it will literally contract all by itself. That cell will just sit there and contract at a rhythm. So we call that property rhythmicity, and we're actually going to uncover why the heart is rhythmic like that as we go. A little spoiler is it's leaky to sodium, okay, which means that heart cells have a tendency to self-depolarize, right? So when they depolarize, they contract, then they relax, then they leak a little bit more, and they contract again. Okay, so more on that later. Okay, if we zoom in and look at the cellular structure of heart muscle, we see a lot of similarities to what we've been talking about for the last week, which is cardiac or skeletal muscle, right? We see the patterns, alternating patterns of light and dark that are the hallmark of sarcomeres, right? So cardiac muscle does have sarcomeres just like skeletal muscle. The big difference in the sarcomere arrangement is that in the heart, the sarcomeres branch. In skeletal muscle, they are all parallel. which means a skeletal muscle contracts only in one direction. Because of the branching characteristic of the sarcomere, so like here's a branch, this one fiber became two, right? Here's another branch, here's another and another, and so on. So what this means is it means that the heart can wrap around. It can have a three-dimensional structure. And the branching cardiomyocytes, the branching sarcomeres, do in fact do that. So instead of just a point A and a point B, here we have a volume that's entirely surrounded by heart muscle that can all squeeze at the same time, right? So the heart essentially evolved not to shorten, but to shrink its volume under pressure, right? It's going to generate pressure, get smaller, and therefore push blood forward. Okay. Cardiomyocytes do have a sarcoplasmic reticulum, just like muscle, just like skeletal muscle cells do, but it's much less developed. So instead of getting this really tight integration between excitation and contraction, we have a looser, more time-based system instead, as we'll talk more about in a minute. Okay. So some other key differences. Each cardiomyocyte has just one nucleus. That's different than a skeletal muscle. Remember, they're conglomeration cells, so they have oodles and oodles of nuclei because one cell is essentially 10, 20, 30 cells joined together. That doesn't happen in the cardiomyocyte, so each one has a nucleus. So it is possible to really distinguish one cell from another, right? So this whole thing is one cell here. This whole thing is one cell, and so on. Now, binding the cells together, like we see here, 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 and here, are special structures called intercalated discs. And they essentially are two kinds of junctions in one. Okay, so if we have cardiomyocyte B and cardiomyocyte A, right, in an intercalated disc, we have two kinds of junctions. One looks like this. It has kind of a flat plate on the inside of the membrane, and then it has a stick that connects one flat plate to the next. You can imagine that this kind of a protein would tend to hold these two cells together, right? I think of it like it's like a rivet or a nut and bolt, right? It's stuck together. Well, these structures are called desmosomes, and they exist to conduct contraction from one cell to the other. In other words, when the heart contracts around the blood that's in it, what we don't want is for a bunch of the cardiomyocytes to kind of pop open and let blood come out, right? We need to have a really firm binding. So that's the desmosomes. The other thing we find in the intercalated discs are cell-to-cell junctions that look like little straws or little tubes. Those are called gap junctions, and gap junctions are present to allow molecules or ions from one cell to the adjacent cell. Gap junctions allow many myocytes to work as one cell, right? Because as ions move from cell to cell, action potential also moves from cell to cell. Okay, so these two structures, the gap junctions and the desmosomes, allow the heart to act as another functional syncytium, right? It's a group of cells that tends to work together. Now, ultimately, we technically have two syncytia. We have the atrial syncytia and the ventricular syncytia, and they're connected together by a special group of cells called the AV node, which we'll talk about when we talk about the conducting system. Okay, so intercalated discs, desmosomes, and gap junctions. Those are present in these structures right here. Okay, so we've been talking about action potentials and how they form. Specifically, that when you open channels that conduct ions on the cell membrane, we trigger a membrane potential change. And that membrane potential change can make other things happen because there are also channels that respond to that membrane potential change. Like we've been talking about sodium and potassium voltage-gated channels, right? Okay, so in the cardiac cell, instead of seeing a very rapid up and down action potential, we see an action potential that has a different shape. We still have our strong, quick upstroke. We have a little bit of a downstroke, and then we have this region called the plateau region, where the membrane potential has gone up, and it stays up for a while, then it falls back down, and the cell repolarizes. Okay, so this region number 2, the plateau phase, is what's different. Now, another thing that's different about this pattern is the time that it takes. So here you see we're at about 300 milliseconds, right? So a millisecond is a long time in terms of muscle contraction or nerve conduction. So it means that this whole action potential is taking place in 100 times as long as a skeletal muscle action potential takes place. So it's much longer in time, okay? So let's take what we know and look at this specific action potential. Okay, so at area Z, or point 0 here, right, so we have our rapid upstroke. Not surprisingly, rapid upstrokes are usually caused by lots of sodium entering the cell, right? So there's no difference here. We open voltage-gated sodium channels, sodium comes rushing in. It has a tendency to depolarize the inside surface of the membrane. So we see a movement towards positive, right? Now at point number 2, which is right here, we have two things that happen. Number 1, the fast sodium channels close, okay? And number 2, the slow calcium channels open. Now there's a new player. We haven't seen calcium channels and action potentials before, right? We've only talked about sodium and potassium. Well, cardiac muscle has these unique voltage-gated calcium channels that open at the membrane in response to depolarization from fast-gated sodium channels, right? So sodium entry leads to sodium entry leads to calcium entry. All right, so typically the extracellular fluid concentration of calcium is higher than the cellular concentration. So it means when we open these calcium channels, calcium is going to tend to come into the cell. Now, not surprisingly, it's not just going to sit there and do nothing. That calcium is going to become the trigger for muscle contraction, just like it is in skeletal muscle. But the mechanism is a little bit different, okay? So at point number 2, we have these slow calcium channels open. These channels allow primarily calcium in, also a hair of sodium too. They're not entirely specific. They're slow to open. They stay open for a long time. 0.2 seconds, 200 milliseconds. That's forever in physiologic terms, right? So they open and stay open for a long time. While they're open, the calcium is entering, right? That should be Na+, not Na++. Can't break the rules of chemistry, not even here, right? But calcium enters along with some sodium. All that positivity coming in helps to keep the membrane potential at around 0, okay? Now here, unlike skeletal muscle, potassium's pattern is quite a bit different. All right, so these two graphs line up. This is membrane potential on the y-axis, time on the x. Here what we have is outward versus inward by ion, okay? So we can see that at the rapid upstroke of sodium, we have lots of inward movement of sodium, right? So that makes sense. That matches what we already know. Now, interestingly, we see potassium starts out with a relatively high outward flow. It drops down to almost nothing, and then it picks back up. This is a very different pattern than what we saw in the action potential that we looked at so far. And then calcium, here's that calcium entering during the plateau phase. All right, so the easiest way to put this is, unlike skeletal muscle, potassium outflow is much less during the depolarization and is only triggered late in the action potential, which is why you see the change only way out here. So the point of this potassium pattern is if potassium was leaving, in other words, if all the potassium channels were open, during that plateau phase, we would tend to get a repolarization, right? Because remember, the nurse potential for potassium is hugely negative, right? So if potassium channels were open at this point, let's say right here, well, our action potential would just come all the way back down. So the sodium channels have to be blocked in order to maintain this calcium plateau that allows calcium entry. Okay? So sodium first and fast, then a potassium blockade with calcium influx, and then the potassium channels do eventually open at number 3, and we get our repolarization back down to baseline. Okay? All right, so that action potential pattern means that, and that plateau and the length of the thing, it means that, hold on, that first word in the second thing should be cardiac. Cardiac muscle contracts slower and for a longer period of time than a muscle twitch. Okay, that was my mistake there. It also means that cardiac muscle has a longer refractory period because of that potassium pattern. This is not a bad thing, okay? As we'll learn a couple of points here in the next week or two, the heart has an upper limit on rate, okay? If you make the heart pump too fast, it doesn't have enough time to fill up before it contracts. So the faster the heart beats, the less well it's doing its job, right? So having a longer refractory period helps to block the heart from getting, 230, 240, 250 beats per minute, which isn't going to do any good anyway, right? So we have a longer refractory period. Cardiac cells also are leaky. In particular, they have a sodium leak, which exceeds the activity of the sodium-potassium pump. What that means is that if you put your little meter in a cardiac muscle cell and wait, it will slowly depolarize up towards 0 till it fires an action potential, comes back down, and then it'll do it again. Remember that rhythmicity we talked about? This is the mechanism of that. Okay, so we have leaky sodium channels. We're going to zoom in and look at that when we talk about the conducting system, because that leak, changing it, in other words, making it leakier or less leaky, is how the sympathetic and parasympathetic nervous systems affect heart rate, right? Is by that leakiness right there. Okay, so this sodium leak means each cardiac cell has a tendency to depolarize on its own. Well, remember, this is a functional syncytium. We don't want 150,000 muscle cells all depolarizing at a different time, right? That is not going to make the heart contract as one thing. So each cell, as we go from the top of the heart to the bottom, there's a tendency for the cells to beat a little slower. So like the cells that you find deep in the ventricle, their automatic rhythm is like 30 beats per minute. That while the cells you find in the SA node of the atrium, their rhythmicity is between 60 and 80 beats per minute, right? So as we move through the heart, the tendency to contract becomes slower and slower. Now what that means is it means that the heart's rate, the contraction of the whole thing, is going to be set by the cells that have the fastest depolarization. All right, and I'll explain that more to you when we get to the conducting system a little bit later on. Okay. think we covered all that stuff. Okay, so if excitation, contraction, coupling is not the same system as we saw in skeletal muscle, what is the system? Well, we do not have troponin, we do not have tropomyosin that functions in the same way, okay? We do have actin and myosin. There is troponin in cardiac muscle, okay? And there is tropomyosin. In fact, we test for it when we're looking for myocardial infarction. But in terms of our mechanism of action, the mechanism of action is quite a bit different. Okay, so we have our action potential, right? Now remember, for heart muscle, this is typically triggered by autorhythmicity, right? It leaked itself into having an action potential. That action potential is going to travel down the T tubules. We still have T tubules in cardiac muscle. And that action potential is going to open a voltage-gated calcium channel present on the membrane. Calcium is going to come rushing in. This calcium that's coming in from the outside will in turn trigger the opening of additional calcium channels on the sarcoplasmic reticulum. And together, the calcium from both places are going to become the signal for contraction and the trigger for troponin, tropomyosin's interaction with actin and myosin. Okay, I think I may have misspoke. Cardiac muscle has troponin and tropomyosin, and it still responds to calcium, all right? So calcium binds to troponin, moves tropomyosin away. We get the binding sites, right? It is a different troponin and tropomyosin than what we find in skeletal muscle. Okay, I think I may have confused that, so sorry about that. Okay, so then we get contraction to occur, same mechanism. The big difference here is we don't have the DHP receptor like we have in skeletal muscle. Okay. Instead, we have calcium from the outside triggering release of calcium from the inside through those ryanodine receptor channels. All right. Now, how do we get the heart to relax again? Well, when the action potential is complete, calcium stops entering the cell. That causes the closure of the action potential being finished closes this calcium channel. The absence of calcium coming in then triggers the closure of this calcium channel. And now we're into pumping, right? So we have a calcium pump that pumps calcium back into the SR. And then we have a pump, sodium-calcium exchanger on the membrane that also evicts calcium from the cell using the power of the sodium-potassium pump. So we get a similar relaxation system to what we saw in smooth muscle, right? We basically have to pump the calcium away in order to get the muscle to contract. And by the time it's all pumped away, well, there'll be another action potential coming around because these are rhythmic cells. Okay. I did check my answers this time. All right, what's happening during the plateau phase of the cardiac action potential? All right, very good. So that's calcium entering, and that's, of course, a big deal because it's that calcium entry that's going to trigger contraction in the heart muscle, right? So it means that if we are watching the action potentials of a heart muscle, right, of a heart muscle cell, we'll see the action potential, and then during that plateau phase, that is when contraction will actually start, right, because calcium is starting to come in. You guys are quick. Okay, potassium enters the heart cell in large amounts when? Good, that's during that repolarization phase, which makes sense because potassium tends to drive the membrane potential back down, right? Because it has a very negative Nernst potential. So very good. The downstroke is almost always potassium. All right, the trigger for contraction in cardiac muscle is, which of those? Okay, so the one I want you to be able to tell the difference between is the red and the blue one. Okay, so release of calcium from SR in response to depolarization, that's skeletal muscle. That's the DHP receptor, right? Causes a big release of calcium from the SR. In cardiac muscle, it's the entry of calcium from the extracellular fluid that is the trigger for contraction. Now, this comes up clinically because if we change a patient's calcium concentration, we're going to affect their cardiac contractility, right? In other words, if you are hypercalcemic, your heart is going to have a tendency to contract for longer and with more force, right? Because the calcium is coming from the extracellular fluid. It's one of the reasons why calcium is in the cocktail that we use, or that I don't use, but that is used in lethal injection, of all things, because calcium is a very rapid heart stopper. All right, the things you learn in phys class, right? In order for heart muscle to relax, what has to happen? Yeah, calcium has to be pumped out of the cell. You could also say calcium has to be pumped into the SR, because that's the other place it goes. But ultimately, the calcium concentration has to be brought down in order for relaxation to occur. All right, who's our winner? I'm going to skip. Okay, so now we've got the heart contracting, okay? It got a signal for contraction from depolarization. Well, so what? Let's zoom out and we'll look at how does the heart muscle itself that you can see with your own two eyes, how does it actually accomplish the movement of blood through the body? Okay, so some basic stuff. 4 chambers, 4 valves. Blood comes in through the right atrium, through the IVC and SVC, that's inferior vena cava, superior vena cava. The right atrium pushes blood into the right ventricle. That's through the tricuspid valve, all right? Right ventricle pumps blood out through the pulmonic valve out to the lungs. That means that the right side of the heart has only to push blood a tiny little distance to the lungs and back, okay? Now, the pulmonary system is high volume, low resistance. In other words, it takes very little pressure for the right heart to move blood to the lungs and back. And I say all that because it means that the right ventricle is smaller and weaker than the left ventricle is. The left ventricle has to build up enough pressure to get blood to all the nooks and crannies of the body. The right ventricle only has to build up enough pressure to get blood to the lungs and back. Okay, so we're going to see a major difference in pressure as we look at that. Okay, blood coming from the lungs enters the left atrium through the PVs, that's the pulmonary veins. Okay, there's 4 of them. If anybody ever asks you to identify a heart, like they hand you a heart and say identify the parts, look for the 4 pulmonary veins, right? 1, 2, 3, 4, they sit on the back of the left atrium. You can get the rest from there. The left atrium pumps blood through the mitral or bicuspid valve to the left ventricle, and then from left ventricle through the aortic valve to the aorta. Now, if all of that is not intimately familiar to you, mark that as a study thing, okay? Because I'm going to take it for granted that you know which valve we're passing through and where all the valves are, all right? Because that's really undergrad A&P. Okay. So we divide up. Remember I said the other day, whenever anything's complicated, we divide it up in pieces so we don't get confused. Well, here's another one. We're going to take the heart's actions and we're going to divide it into two big sections, okay? We have these two words, systole and diastole. Systole is contraction, diastole is relaxation. We have four chambers, two atria and two ventricles, which means we have systole for the atria and we have systole for the ventricles, right? Because we have two spots that contract, technically four, but we'll talk about two atria and two ventricles. Okay, so if we start at time 0 here, time 0 is end of diastole. In other words, the heart has been relaxed for some time. It's nice and filled with blood. So what happens first? We get atrial systole. That means the contraction of the atria. Now, as heart chambers go, the atria are kind of pathetic, okay? They really don't have very much muscle. They're not very big. So their contraction is not an enormous affair, okay? The way I think of atrial contraction is it's a little bit of a bump is all you get, okay? And I'll show you in my pressure graphs what I mean by that later. But here's the little bump of atrial systole. All atrial systole does is it pushes a little extra blood into the ventricles, right? Through the AV valves, the mitral valve and the tricuspid valve are together known as the AV valves, atrioventricular valves, right? So that's atrial systole. You can see it doesn't last very long. Okay, well, what happens next? Well, after the atria have contracted and pushed their little bit of blood to the ventricles, next up is the ventricles contract, okay? So this whole big purple section here, this is ventricular systole. So in a test question or when you're reading for MedPath, let's say, if all they say is systole, they're talking about ventricular systole. All right, almost nobody talks about atrial systole unless you're in a cardiology clinic looking at something very specific. So when people talk about systole or diastole, they're usually talking about ventricular systole and diastole. So what we have here is in purple is ventricular systole. And you can see that the first thing that happens when the ventricles start to contract is it slams the valves closed. Right? Because remember, blood would want to go backwards. We're not going to have that, so the valves close. Then the ventricles actually get smaller. They squeeze and get smaller. As they get smaller, they eject blood into the pulmonary artery and the aortic artery. Okay? So then at the end of ventricular systole, the ventricles begin to relax. And as they begin to relax, we get filling. Okay, so during filling, the blood that's coming from the lungs and from the body are filling up the atria while the ventricle continues to relax. As it reaches the end of its relaxation, a point in time we called end diastole, end of diastole or end diastole, the heart is as full as it's going to get before the next contraction, right? We call that EDV, the end diastolic volume. And then we cross the circle again, atria contracts, ventricles contract, and so on, okay? So these are the phases of the cardiac cycle. Now, we got a little quick video. Let's see if our video plays. Yeah. I just like the graphics in this because it really shows you the anatomy. All right, so right side, left side, you can see the valves, right? Apparently I don't have sound, so I'll have to walk you through it. Okay, so here is your the atria. This is right atrium, left atrium, right AV valve, left AV valve. You can see blue blood coming back and then ejected out into the pulmonary arteries. On the red side, right, we right through the left AV valve and then ejected out through the aorta. You can follow that over and over again. It just kind of puts that in motion. Okay, you can turn my lights back on for me. This is, believe it or not, how I prefer to look at it. Now, it's probably not how you prefer to look at it. This is our first big graph, and we're going to take it slow, not to worry, okay? And we have 12 minutes before we're done for today, so we'll probably pick it up a little bit more tomorrow. All right, so first off, axes. Whenever you're encountered, given a graph to look at, identify your axes. This is what I call a compound graph because we got more than one thing going on here that we're looking at once. Okay, the red lines, red and dashed lines. The y-axis is pressure. All right, remember, who's taken a physics class? All right, very good. I use physics a lot in my descriptions of things. Okay, so what is pressure? Pressure is, it isn't always a squeezing force. Sometimes it's a squeezing force, but ultimately pressure is potential energy. It's a way for things to move from one place to another, right? It turns out in our heart, in the cardiac system, pressure is what's determining everything that happens in a heartbeat, okay? So the pressure becomes hugely important. So that's what we have here is pressure on this line. The x-axis is time. Now down here we have volume. Okay, the blue line is volume. What volume in particular? The ventricular volume. So the volume of one of the ventricles. Okay. Now we can of course measure that. So when the ventricle contracts and pushes blood out, does its volume go up or down? Down. Right? We're going to push blood out. So the volume that's left is going to go down. Okay? So that's the blue line. The yellow line is what we call the electrocardiogram. This is an external measure of the electrical activity of the heart. We have a whole talk on the EKG. Okay? So we'll talk about how all the pieces come together. But that's on our graph here to show you sort of where we're at. And then at the bottom, this is fancy name phonocardiogram, not so fancy name heart sounds, right? When you listen to a patient's heart, you hear the lub-dub, right? Lub-dub is S1 and S2. The S1 is the first heart sound, S2 is the second heart sounds. Heart sounds are made when valves close, okay? Think of it like a door. If you really want to make a stink about a thing, you slam the door, right? Closed. Making a big stink by slamming it open doesn't work so well, right? It's got to bang into something else. So valves snap or make a sound when they close. All right, so let's run through a cardiac cycle. Okay, so first off, we'll start with our ventricular volume. Okay, so we're coming in here kind of level, and then we have this bump up, right? Our volume increases ahead of ventricular contraction. That's atrial systole, right? So the atria contract a little, push a little blood into the ventricles. That causes an increase in the volume of the ventricles. Okay, so that's atrial systole. Now, we see in our EKG, we're in our QRS complex, which you'll learn later, is the trigger for ventricular contraction. All right, so after atrial contraction, now we're in ventricular systole right here. Okay, so let's look at our pressure graph first. So when the ventricle starts to contract, okay, the first thing it's going to squeeze, right? Well, as it squeezes, it builds up pressure in the ventricle. Okay, squeezing builds up pressure. We see that as this steep red line right here. The pressure in the ventricle is getting dramatically higher relatively quickly, right? Now, if we look at the volume graph, do you see how while the ventricle is steeply getting more pressure, the volume isn't changing? See that? So the volume is flat. What's happening here is when the ventricle starts to contract, the first thing it has to do is it has to generate enough pressure to push the aortic valve open, right? On the other side of the aortic valve is relatively high pressure blood. What's diastolic blood pressure? Give or take. 80, right? 80 millimeters of mercury. Well, our ventricle is down there at 4 millimeters of mercury, see? So in order for the heart to start pushing blood into the aorta, it has to generate enough pressure to push that aortic valve open. We call that period of time when the ventricle is building up pressure but not changing volume, we call that isovolumetric contraction. Same volume but contracting. Energy is being spent in that time. It's a little bit like my analogy of a book on an outstretched arm, right? You know, before you can lift the book to the ceiling, you have to support the weight of the book first. So that's what isovolumetric contraction is. All the valves are closed, the ventricle is contracting. Now, when the ventricle contracts enough to have enough pressure greater than the pressure in the aorta, we get to this point right here, which is the aortic valve opens. And it opens when the pressure in the ventricle exceeds the pressure in the aorta. All right, so now, finally, we have a heart that's contracting, and we have a valve that's open. Now the heart can start doing its job, which is ejection, right? It's going to push blood out into the aorta to move blood around the body. So first we see contraction, and then at the top of the contraction, we start getting into relaxation. Now, what's happening with the volume? Well, once that valve is open, the volume is getting smaller and smaller and smaller. Where is this volume going? It's being pushed into the aorta. That blood is being pushed into the aorta. The heart is ejecting. It's pushing blood out. Okay, so now we get into relaxation. So the heart has contracted. Now it's starting to relax. And as it relaxes, the pressure falls. When the pressure in the ventricle falls below the pressure in the aorta, the aortic valve closes. It snaps shut. That's S2, right? Thud. It closes. Well, now we have the case where all the valves are closed again. Only now, instead of the ventricle contracting, it's relaxing. Oh, come back here. So we call this time isovolumetric relaxation. We don't see a change in volume, right? But we do see a change in pressure. Why? Because we're below the pressure of the aorta, but we're still above the pressure of the AV valves. So nothing can get in or out. We have a flat spot on our volume curve. Now, when the pressure sinks below the atrioventricular valve, okay, that means the AV valve is going to open. When it opens, blood that has been pooling in the atria, right, now starts entering the ventricle, and we get filling. You see, the ventricle is filling up passively as blood trickles into it from the body. Then we get atrial systole again. We get our little bump up, and now we go around the bend again. See that? So the atria acts as kind of a primer pump. It nudges blood into the ventricles. But the real work is done by the ventricles, right, between isovolumetric contraction and isovolumetric relaxation. All right, so we see that the aortic valve opens when the pressure in the ventricle exceeds the pressure in the aorta. The aortic valve closes as the heart relaxes and pressure in the ventricle falls below the pressure in the aorta. See, so we have opening and closing. Then on the AV valves, so that's your mitral valve and tricuspid valve, right? It opens when the contraction first begins and closes when contraction first begins. The AV valve opens as contraction ends, right? And I said it's all about pressure. So the AV valve, for example, opens when the pressure in the atria becomes greater than the pressure in the ventricle. The AV valve closes when the opposite is true, when the pressure at the atria is less than the pressure in the ventricles. Okay, we're going to go over this a few more times, so bear with me. Okay, we can talk probably a little bit about this one. This is that same information. It's just kind of put into a smaller space. Each one of those numbered areas, those are areas that you should understand what's happening at those areas, right? So at number 1, we get atrial contraction. Number 2, we have our ventricular filling from the atria, right? At number 3, the atrial systole ends and the AV valve closes as the ventricle begins to contract, right? Number 4 is that isovolumetric contraction. Number 5, this is ejection, okay? I wish there was a point here where the aortic valve opens, because that's another spot I'd want you to know, so call it 4.5, right? And the aortic valve opens when the pressure in the ventricle exceeds that of the pressure in the aorta. We get a continuing contraction. Now, what makes us turn this bend and go back down? What makes relaxation occur? The action potential's over, right? So the action potential's over, calcium is pumped back out, another action potential hasn't come along yet, so we're in natural relaxation. It's just part of the pattern. It's just what's happening in the blood-moving side of things is we get a peak of contraction. Anybody have any idea what pressure that usually is? It's right up there. 120 to 130, right? Systolic blood pressure. And then we get relaxation. As the ventricle relaxes, its pressure falls below that of the aorta. Thud, the aortic valve closes. Then we get isovolumetric relaxation until the ventricle has relaxed enough that the pressure in the atrium becomes greater than the pressure in the ventricle. Then that allows the AV valve to open and we get filling again, right? And then from filling, we go around the bend again. Now, the dicrotic notch is a phenomena we see. That's this little guy right here. We see it here too. If we were measuring aortic space, it's right here. So the dicrotic notch is difficult to explain, all right? But what is happening there is the aorta has a little bit of elasticity to it. So when the aortic valve closes, we get kind of an increase in pressure in the aorta after the valve closes. That doesn't mean the heart has anything to do with it. That the dicrotic notch is an intrinsic characteristic of the aorta. The aorta gets stretched a little at maximum systole, and then it recoils. And that recoil sends the pressure up a little bit. Okay, so you'll remember this is ventricular pressure, right? This is ventricular volume. This is the electrocardiogram, and these are the heart sounds. Okay, so a few things to point out. We haven't talked about EKG yet, but we are soon, very soon. What I want you to see here is that the EKG change precedes the contraction change. All right, so like we see the heart is contracting in this area, but the QRS complex, the beginning of the EKG that triggers this contraction is ahead of, in time, the contraction itself. Now, I think that makes sense. Before a cell or the heart can contract, it first has to depolarize, right? So we see EKG changes first. So that means that we have excitation before contraction. We see the electrical movement change. We see the electrical status of the heart change before it actually starts contracting. That makes sense with what we've learned because it's that electrical change that's going to trigger those calcium channels to open, calcium to come in, and that is what's going to trigger contraction. So it does make sense that excitation comes before contraction. Third point, heart sounds are made by valves closing. Okay, so if we look at our heart sound areas, okay, this is S1, this is S2. This is actually S3, which is an abnormal heart sound. More on that later. But S1 occurs when the AV valves close, right? S2 occurs when the aortic and pulmonic valves close. Now remember, in a normal functioning heart, the valves work in pairs. So the AV valves are supposed to close at the same time. The aortic and pulmonic valves are supposed to close at the same time. Now, there are some things we can ask patients to do which will split the heart sounds on purpose. For example, we'll ask patients to take a big breath and hold it, and that has a tendency to split the left and right AV valves so you can hear them individually. More on that next semester. But valves make a sound when they close, not a sound when they open. Be sure you know and understand the isovolumetric contraction and isovolumetric relaxation areas. The way I conceptualize that is when all 4 valves are closed, nothing can move, right? But in order to open valves, you have to build up pressure or release pressure on the relaxation side. So it means that we have these periods of time when the heart is contracting or relaxing, but nothing's moving, all right? Ejection is the fancy word we use for the heart doing its job, which is pushing blood out into the circulation. Ejection occurs between when the aortic valve opens and when the aortic valve closes, right? That is the entire period of ejection. Filling happens, we can see ejection on the ventricular volume graph as well as filling. Okay, so I said this is ejection. Another way to look at ejection is a shrinking of volume, right? If the ventricle's volume is shrinking, well, where's the blood going? Out into the circulation. That's ejection. Now, immediately after systole, we start to see the volume increase again. This is filling. Ventricular filling is divided into 2 phases. The first phase is passive filling, okay? And that is basically blood trickling through the atria, trickling through the open AV valve and filling up the ventricle. Then we have active filling, which is right here. Active filling occurs as atrial contraction occurs, right? So in a given heart beat, about 2/3 of the filling is passive, 1/3 in time anyway, is active. Okay, atrial versus aortic pressure. So what I'm showing you here is the dotted line is atrial pressure. Okay, so we can see that never does the atrial pressure get above 10 millimeters of mercury. That is very, very low, okay? And that's important because atrial pressure is supposed to be the lowest blood pressure in the body. The reason for that is, remember from physics, things always move from areas of high pressure to areas of low pressure. Well, ultimately, we want all the blood in the body to get back to the atria, particularly to the right atrium. So it needs to be the lowest pressure so that all blood ends up flowing there, okay? Now, the significantly different than that is aortic pressure. That's up here, dotted line up here. We see that aortic pressure runs between diastolic blood pressure and systolic blood pressure. So from 80 millimeters of mercury to 120 millimeters of mercury. Well, that is a huge difference, less than 10 to 80 to 120. So what I'm pointing out here is the heart's job is to pressurize blood that returns to the atrium so that it can then have enough pressure to actually get into the aorta and travel down the roller coaster of the body again. Now, by roller coaster, this is what I mean. You know, you've all been to an amusement park, right? They haul you up a high hill, and then they let you go. And by the time you get back to the station, you've burned up a lot of your potential energy, right? Well, essentially, the same thing is happening in your cardiovascular system. The heart pushes the blood up the hill, up the high pressure gradient. From there, it's all passive movement until we get back to the atria again. Okay? Atrial versus aortic pressures. We have 2 important volumes that we're going to talk about over and over and over for the next couple of weeks. One is EDV, end diastolic volume. That is the heart at its most full. The other is end systolic volume. Heart is most empty. All right, so at the end of diastole, is just before the beginning of systole, right? We can agree on that. Okay, so if systole begins when the ventricle starts to contract, well, where is the end of systole? Well, it's right about here. And the end systolic volume, I'm getting confused. End diastolic volume, okay, at the end of diastole, so when the heart is done relaxing, getting ready to contract, its volume is biggest, right? It's most full. All right. End systolic volume is at the other end of that graph, way down here. At the end of systole, the heart has pushed all the blood out it's going to push. All right, so the difference between those, end diastolic volume minus end systolic volume, is what we call stroke volume. That is how much blood left the heart in one contraction. Okay, now, what we're going to see in the next week or two is stroke volume is a variable. The heart can change how much blood it outputs in a beat. And that is one of the ways that we control what's called cardiac output, or how much blood the heart pumps out per unit time, particularly per minute. Okay, so EDV and ESV are important points on this graph. Okay, the last thing I want to point out to you is that pressure makes all the difference. So, like here, we have the atrial pressure wave in the dotted, and we have the ventricular pressure in the red line. Okay, whenever the lines cross, a valve is going to open or close. Okay, so for example, when our ventricular pressure exceeds our atrial pressure right about there, blood's going to try to flow backwards down its pressure gradient. That's going to close the AV valves, right? If we climb all the way up here, we see that when the red line, when ventricular pressure exceeds aortic pressure, a valve's going to open. That is, the aortic valve is going to get pushed open by the contracting ventricle, right? Now, on the other side here, when our ventricular line falls below our aortic pressure, the aortic valve is going to close, right? And then here, as the heart continues to relax, when ventricular pressure falls below atrial pressure, we'll get our AV valve to open, and then filling can begin. So ultimately, what opens and closes valves are pressure differences on each side of the valve. Okay? Okay, so stroke volume, key measure of cardiac function. So I just have it here in a different form. One way you can think of the heart is as a pump, right? And if you're going to use a pump, first you have to fill the pump, then you have to empty the pump, right, in order to push anything out. Well, here what we see is at end systolic volume, which is over here, okay, at the end of systole, we've completely emptied the pump. Well, then we pull the pump back up, we fill it, okay, so this is ventricular filling, until we get to the maximum that the heart can hold. Then we begin to pump and push that fluid back out. Okay, so it's the same idea, just in different pictures. ESV, EDV, and stroke volume. Okay, now cardiac output is taking stroke volume and then we multiply that by heart rate, so we get it per unit time, right? More on that later. Okay, so let's talk a little bit about how valves function. Valves, all the valves in the heart are passive. They do not close using muscular energy. They close in response to pressure gradients. When the blood tries to drop backwards, it ends up filling the cups of the aortic and pulmonic valves, for example. So if blood pushing through this way pushes these cups open because they're smooth on the bottom, right? Well, if blood tries to flow the other way, these cups get filled with blood, and that pushes the cups together, right? So it prevents backflow of blood. These are the easier to understand. They flatten in the outbound direction, and they fill and close in the backwards direction. Well, what about the AV valves, the mitral valve and the tricuspid valve? Well, they look a little different, but they work in the same way. When blood starts to flow backwards, that blood pushes these leaflets, these thin, durable membranes here, the cusps. It tends to push that, it tries to push it back into the atria. So what we get kind of like a parachute effect, right? Where these valves poof up because blood's trying to move backwards. But they're tethered, just like a parachute, it's tethered to your harness. Well, in this case, the valves are tethered to the inside of the ventricle using what we call chordae tendineae. Okay, these are little thin but very tough fibers that hold, on one end they're connected to the cusps of the valve, and on the other end they're connected to what's called the papillary muscles, which are extensions of the ventricular muscles whose only job is to hold on to those chordae tendineae so they don't flap backwards. Okay? Now, what I don't want you to think is papillary muscles do not close the valves. Okay? Don't be tricked by that, even if maybe that's how you learned it incorrectly in the past. All right? All the papillary muscles do is hold on to the cords of the parachute, so when the blood tries to go backwards, it can't flop. Okay, so here's what I'm trying to say by that. Okay, so this is our bicuspid valve, all right? Papillary muscle, right? Chordae tendineae, this is our AV valve. Okay, so when blood tries to flow backwards, in other words, when the pressure here is low and the pressure here is high, okay, well, the blood fills these cusps, and what wants to happen is it's going to flap this way, right? Which is absolutely what we do not want. What we want is the edges of the cusps to be held in place so that when this fills up with blood, right, it closes and pushes that together. Okay, so that's the AV valve function. Papillary muscles hold on, but they don't close the valves. The pressure does that. All right. Another a graph showing some important characteristics of the heart. Okay, we'll start. This is the left ventricular pressure on the y-axis, left ventricular volume on the x-axis. So this is what we call a pressure-volume loop, which are notoriously difficult to understand. So you have to kind of take it a little bit at a time. So let's look at the blue line, all right? What we're doing there is we're looking at the volume of the ventricle as we fill it with blood passively, right? So imagine we've got a big syringe of blood, we've stuck it into the ventricle, and we're injecting that blood into the ventricle, okay? So as we inject more and more blood, our ventricular volume is going up, right? But at some point here, about 150, our pressure starts to go up too, even though the heart's not contracting. Why? Because we have a limited volume in the heart, right? The heart is not stretchy like a balloon. So as we add a little bit of blood, it stretches really easily. But as we try to add a lot of blood, the heart itself is restricting more movement. So we get an increase in our pressure. Now, if we look at the systolic side, what we're doing here is for a given ventricular volume, how much intraventricular pressure can we make? And what we see is, compared to the blue line that's nice and smooth, the green line has a kind of S shape to it. And what this points out to us is that the heart can actually generate more pressure when it is a little overfilled. Okay, that's my point of this graph here. It describes what's called the Frank-Starling relationship, which is that when you fill the heart a little extra, it contracts a little stronger and a little more completely. All right? It's one of the ways our heart self-balances so that our cardiac output matches our needs. Okay, so the green and red lines are sort of intrinsic characteristics of the heart, right? Now, the red line is what's happening in a given contraction, okay? So from A to B, we have our ventricular filling. You'll notice that most of that filling is passive, right? Then we get a little bump up where we get our atrial systole, okay? Now we get into ventricular systole, so the ventricles start to contract. That drives the mitral valve closed. We have our period of isovolumetric contraction. Nothing can move, but the pressure is building up. Eventually, we build up enough pressure to open the aortic valve. Now, our volume is going down, so we're moving from right to left in our volume, even as we continue to go up at first in our pressure. See that? So we're ejecting blood, volume is shrinking, at a high pressure. Now, when we turn the corner here and our pressure starts to decline, which is due to diastole, okay, where it's due to the heart relaxing. When the pressure in the aorta exceeds that of the ventricle, the valve closes. We get our isovolumetric relaxation until the pressure comes down enough that the pressure in the ventricle falls below that of the atrium, and then we're back into filling again. So this pressure volume loop is one way of looking at the heart's function. Okay. Now so how do these two graphs relate? Essentially, the green and blue graphs are the maximum container for any given red graph. In other words, for any given heartbeat, it's going to be within the blue and green lines. All right. Now, this is not very clinically relevant, if I'm honest with you. What I'm really trying to show you is how pressure moves blood around the heart, okay? In other words, are we going to be doing a lot of pressure volume loops on exams and stuff? No, we are not, okay? You may occasionally see one in a cardiology rotation, okay? This is more understanding the properties of the heart, not how we take care of patients with heart problems. Okay, so really the red circle is the one I'm most interested in you understanding, and ideally note how the red circle relates back to the master graph here, right? Because it is presenting the same information. It's just instead of doing it over time, it's putting volume next to pressure. Okay, yes? So for the red graph, when you're talking about the ejection, the period of ejection, you said when it's ejecting blood, it's at a higher pressure, and so as it's pushing out, the volume of the heart is just decreasing? I was talking about two things at once. Okay, so when we go from here to here, two things are happening. Number one, the volume is getting less, right, because we're moving on the x-axis from here down to here, right? So volume is shrinking. And then our pressure is also changing. So first we get an increase in pressure as the heart continues to contract. And then it starts to relax as the heart moves into diastole. Okay? All right. Okay, so Frank-Starling relationship. It's an intrinsic characteristic of the heart. It actually goes all the way back to sarcomere arrangement. You know how we talked about in muscle, if a muscle is too stretched out, it gets weak, and if it's too compressed, it gets weak? The heart, in its natural, normal, resting state, is too small for its maximum contraction. This is not a mistake. This is a good thing, because it means that when we increase our cardiovascular needs, in other words, when our cardiac output goes up, and the heart gets a little more stretched, it actually contracts better than it does at rest. So it means that we're sort of optimized, our hearts are optimized for a higher cardiac output than we have at rest. This makes sense for keeping us alive in nature, so to speak. So the Frank-Starling relationship, intrinsic, the The more work it has to do, the better it can do that work, is a simple way to put it. When the heart is more stretched, it's more able to contract more completely. So, putting that in math terms, it means that as EDV goes up, because remember, end diastolic volume is how full the heart gets. So if we're going to stretch the heart, that number goes up, right? Frank Starling says as EDV goes up, ESV goes down. So the fuller the heart is, the smaller it is at the beginning. This is really good for stroke volume because we're increasing the stroke volume because of our higher EDV, and we're increasing the stroke volume because of our lower ESV. So it means that more blood in is more blood out, which is a good characteristic for a heart that has to keep in balance with our cardiovascular needs, right? All right. So how do we control this thing? Well, we've talked now at length about sympathetic and parasympathetic. Sympathetic increases rate and contractility. It does that by effectively raising the membrane potential, establishing a higher baseline. That means that the cardiac cells depolarize more rapidly, and we get a faster heart rate. Parasympathetic does the opposite. It decreases the rate by lowering the resting membrane potential, particularly in the SA node. So this is that innervation. We have our vagus nerves that directly innervate the SA node and the AV node, and then we have our sympathetic nerves that come in from the sympathetic chain. There's not just one nerve here, there's a bunch of little nerves that supply the heart. More details on that as we move. And to remind you, sympathetic and parasympathetic both in play all the time, right? So it means that what we see at any given time is sort of the balance between sympathetic and parasympathetic stimulation. All right, so what about potassium and calcium? You know, we've seen how these ions play a role at the membrane. Well, do they play a role in the heart itself? Absolutely they do, okay? So when potassium levels in patients are notoriously problematic, okay? How many of you have worked in healthcare? Okay, all of you. How many of you have seen potassium issues in patients? Yeah, see what I mean? All right, so the issue with this is simple. The vast majority of potassium in our bodies is inside of cells, okay? That's how it's supposed to be. Now, when we sample potassium from a patient, where do we get it from? The blood, extracellular fluid, right? So it means that we have this problem. We're measuring the potassium in the extracellular fluid, even though almost all of it is in the intracellular fluid. Do you see the problem? So it means that getting an accurate potassium level on a patient is more problematic than you think. Okay, so that's first step. So number one, most potassium issues we see in patients are lab errors, not patient problems. Okay, so that's point number one. However, people get honest to goodness potassium problems too. And in this case, either way is bad. Potassium levels that are too high or potassium levels that are too low both cause problems. Too high, and we get a resting membrane potential that's too high, so we get a twitchy heart. Too low, and we have the opposite problem, right? So both of those are a problem. Calcium ion, as I alluded to the other day, is also an issue. Too much calcium, the heart has a tendency to be too contracty, right? In other words, it can go into an arrhythmia. Too little calcium, and the heart doesn't contract enough. So calcium levels, you would think calcium levels would play a bigger role clinically in the heart than potassium levels do, but they don't. The reason for that is we have much better systems for controlling calcium levels in our bodies than we do potassium levels, particularly in the face of modern medicine, where we very routinely give patients medicines that affect their potassium homeostasis, right? Like Lasix, for example, diuretics, okay? So more on this as we go, but I did want to just point that out. Okay, get your Kahoot stuff out, and let's do a quick one here. Okay, some cardiac cycle questions. The The heart has its largest volume when? At the end of diastole, okay? It's had its most time to fill because it's just about ready to contract. The next instant will be systole. So it's as full as it's going to be. That's EDV, end diastolic volume. The heart is contracting, but no blood is moving. Which phase is it? Yeah, that's isovolumetric contraction. Good, which all of you got, so we don't need to talk about that anymore. Or almost all. All right, 3 of 4. Venoconstriction occurs, and the amount of blood returning to the heart increases. What will happen? Yeah, this is the Frank-Starling relationship. This is an example of a level 3 question, okay? Because we haven't talked about venoconstriction, but I told you what it does, right? It's going to increase the amount of blood returning to the heart, okay? So you have to conceptualize that. What does that mean? That means that EDV is going to go up. Well, if EDV goes up, what happens to ESV? Well, it's going to be driven down. That's the Frank-Starling relationship. So yes, the heart is going to contract stronger and more completely. So the stroke volume won't go down, it'll go up, significantly so. It's part of the self-balancing mechanism. It kind of makes sense if you think about it. The more blood that comes back to the heart, the more blood the heart has to push out. Otherwise, you're going to have a backlog, right? That backlog, anybody know what we call that? That's heart failure, right? When we have blood that's pooling up in front of the heart. Okay. Last one. All right, the ventricles begin to contract. What happens? Oh, okay, some of you need to look at this. All right, so right when the ventricles contract, okay, the very first thing that happens is the pressure in the ventricles becomes greater than the pressure in the atria. Why? Because it just started contracting, right? So the pressure starts to go up. Well, as soon as the pressure in the ventricle exceeds that of the pressure in the atria, it's going to close that valve. Okay, so at the beginning of systole, the first thing that happens is the AV valves on both sides, left and right, close as the ventricle starts to contract. That prevents all that contraction strength from just pushing blood backwards in the system, right? Okay. All right, I'm going to skip the animation a little bit. Who won there? Soaring Dragon, nice. Big Dragon fan. Okay. Onward.